talk to us about not just Lapiplasty, but adductoplasty and some opportunities in patient-specific jigs that they've developed. Dr. Santrock's been a part of this process from the beginning with Treese in developing this tool, and really, even if you don't use the tool, like the concepts that have come forward from these techniques have been really valuable for bunion surgery around the world. So it's really the thought that goes into it has been really great, and I think we're fortunate to have Dr. Santrock here to talk to us about sort of the next step in his practice, and then go into the lab with us and show us the PSI, the adductoplasty, and of course the traditional Lapiplasty technique. So Dr. Santrock, thank you for being here. Pleasure to have you. Take it over.
Thanks for having me. I appreciate you all having me here. I'm from Amelia Island, Florida, so the east coast of Florida, not really in the path of the hurricane, but we panic every time. It seems like I'm new to Florida, so every hurricane's new to me. But what I've learned is that you can't ever predict anything. But right now, we're open for business and hopefully going to keep going that way. Today, I'm going to talk to you about adductoplasty, which is part of our suite of options we have for three-dimensionally correcting bunions. And when you think of metatarsus adductus, it may be the first thing on the front of your mind when you're thinking about bunions, but it has become the first thing on my mind when I think about bunions. After doing this intensely for 10 years, what I've learned is that metatarsus adductus is extremely common, and it's far less evaluated and treated than it should be. And what maybe when we're done with this, we'll be able to settle on an idea that if you look for metatarsus adductus and treat it, you're going to make every one of your bunion surgeries better, so that when it's appropriate, you'll have the adductoplasty system available to you. I'm a consultant for Treese, means I'm paid to be here, and thank you all for inviting me. But I want you to make sure you're familiar with all the material you need, so we have support with the corporate team here as well. So one of the things that has come about after looking for things like metatarsus adductus has led us to an algorithm of how to treat bunions. So a patient comes into the office, they're complaining about a bunion, you call it hallux valgus, and the first question that we have actually requested our patients to look for or to talk to us about is whether or not they have MTP arthritis. Once you have MTP arthritis associated with the bunion, you're going to have arthritis surgery. That's what's important to hear about. So that's the first question. It takes us down two different algorithms, whether or not you have arthritis or not. The second question will then becomes metatarsus adductus present. You might say, well, why do you ask that question so blatantly obvious at the beginning? Well, the reason why is it's 35% of the patients who have bunion are going to have metatarsus adductus. Not all of them are clinically relevant metatarsus adductus, but you need to assess it and determine whether or not that's going to be a role in your treatment. So when we look at this scenario, we're going to talk about no arthritis. I'm going to say somebody has MTA, and that's going to lead us down to what we call the 3-2-1 adductoplasty, TMT arthroplasty, a TMT joint arthrodesis. And so that means we're going to move the first, second, and third TMT joints into the corrected position. And we say a 3-2-1 because it has to go in that order. You have to move 3 out of the way of 2, 2 out of the way of 1, and so forth. And so this is the algorithm that we're going to talk about. And it's actually really important. It's actually my favorite part of the bunion surgery algorithm. But you can see by this slide, there are other things there that might make sense as well. If you have arthritis and MTP fusion, it becomes part of the algorithm. And sometimes you combine that with things like adductoplasty. We call that a quad. There's other types of surgeries here. We can go through this algorithm at any time. And we'll go through this. If I can get the slides advanced, we're having a lot of technical issues. I apologize. So how many of you have performed an adductoplasty here so far or online? A couple of you, so that's good. And our system has been set up, if you've been familiar with the Lapiplasty system, the system was set up so that you have available a set of tools to do this reproducibly. And so it's a very standard set of tools that, kind of what I call, they fit almost 90% of the patients that come in or more will fit into these tools as necessary to get it done, but not everybody will. So you're going to hear also about things like PSI or patient-specific instrumentation in the future, this talk as well as what's coming up. So the big thing when you look at the adductoplasty is, how do you know when you need to do it? How do you know when you need to do a 3-2-1 or address the metatarsus adductus? When is it clinically relevant? This tool right here has been really great for us to both explain to other surgeons as well as to patients. And we call it the plumb line. We've published on this. Essentially, a plumb line is a line of the axis of the foot. And it's going to tell you where a corrected first metatarsal will end up if you're correcting through the TMT joint. So if you're doing a Lapiplasty. So if you have enough room or not, the plumb line is going to tell you. So does this animate? This should animate, right? So if you, I think I just click on that right there.
Sorry, if you click on this one, it's still showing this one.
Still showing that one?
Yeah. Sorry about that.
All right, so the plumb line tool. So essentially, you have this tool where you take the part of what used to be Scarlatto's angle, and we're going to draw that out. It's going to be a line that's going to go from the most medial aspect of the first TMT to the most medial aspect of the first navicular cuneiform joint, and we're going to translocate that line to the third point, which is the lateral aspect of the first TMT joint, then extend it out. This has been published. We have found this to be reproducible. This line represents where a Lapiplasty or a first TMT triplanar correction will end up. So you can see here we have enough room to correct it, and therefore we will move the first metatarsal here. This would mean that there's no relative important part metatarsus adductus in this case. However, in this case, we'll draw the lines again, translocate it out, and you can see now we have a problem where there's bone in the way. We cannot move the first into the correct position because we can't have two bones in the same place. So we will move the second and third over with an adductoplasty case and then correct the Lapiplasty. This is how we get that foot nice and narrow and real well aligned. Some important things to think about. This is an advanced tips and tricks kind of case. So the first thing is indication. Who needs it? It's very important to look for. I can't emphasize enough. Probably the biggest number of mistakes I see out of bunion surgery is people not addressing this or not addressing arthritis. It's really part of the algorithm. If you don't look for arthritis, and it has to be, and you have to be really critical about arthritis. Arthritis can be subtle and it can create some trouble that you can deal with without fusing the TMT, but you have to know, or the MTP, but you have to know. But then not addressing metatarsus adductus is surely going to give you a less than favorable result with any kind of bunion surgery you choose to do, whether it's doing through osteotomy or doing it through TMT arthrodesis. Really, metatarsus adductus plays a giant role in success of or failure. So indication is number one. Learn that, learn the plumb line. You're going to set yourself up for good things. Second is really understanding that when you're doing a bunion surgery, it's not like I was taught. It's not like when I was taught 25 years ago that you basically go in, you do the surgery, and take an x-ray at the end. This is an x-ray guided surgery today. This is like a total ankle. And it's actually how we built the system off of was really more like a total ankle, where there's very specific x-ray steps to assure that we're getting into the right positions. We're doing this precise. I mean, we're talking down into the half degree of correction. We're doing 6.5 to 7.5 degrees of correction. It's very, very precise. So you have to use x-ray guidance, which means you have to set up your room really well to make sure you have x-rays in the right position. So setting up your room, some tips and tricks that we do. We're basically going to get the well leg off the table, gives you plenty of room so you can get the C-arm in there. I have converted from sitting to standing. I used to sit for all my foot and ankle foot surgeries, especially. Now I stand so I can get around the C-arm, mini C-arm. And that's the real important thing there. Getting your C-arm set up so it doesn't have to move and you're only moving the foot in and out of the field is very key to this type of a surgery. The steps of adductoplasty are really simple. There's only 4 steps. You plane the joint and release all the ligaments. You make your precision cuts. You compress it down and you fixate. It's not complicated. It really takes about 30 minutes to do this portion of the surgery. Then the rest of your surgery will be to correct your first ray. The sequence of events are essentially you're going to release all the first ray stuff as well first, right? So we're going to release the first TMT. We're going to release the lateral side of the first MTP. Make sure that is mobile and then start our adductoplasty. It will go back and finish in the Lapiplasty incision. But you start with all those releases. It helps the foot become flexible. The foot has been adducted. So we want to make sure that it's now flexible enough that we can correct it all the way over and make it straight without having tethered there and getting a false sense of correction. And how can you do that? Well, your tools are powerful. You can overcome a lot of that deformity with the tools if you misappropriate the tools. So we just do the releases first so you have complete control. And so here you can see when the first is released, how much mobility we can have in abduction, adduction. It's a 2-incision technique. You're going to make an incision that's for the first ray in the standard place for Lapiplasty, just medial to EHL. But you're going to make a parallel incision to that, overlying the third metatarsal essentially. And this is the most important part here is that you're going to be parallel incisions, full thickness, and you're going to undermine all the way, but stay down on periosteum to undermine. Do not try to separate skin incisions. We don't recommend any dissection between the layers, straight down. So this is really a fairly simple approach, although you're not familiar with it most of the time. We don't operate over here very much, so it's not really very familiar. You're also working in a very hypercavus situation, so you feel like you're approaching this from way lateral than it feels comfortable. But it's true, that's where you should be. Metaductus is hypercavus in the transverse plane. So that's going to help you understand this. So that incision usually is about a 4-centimeter skin bridge. Haven't seen any trouble with skin sloughs like this when it's treated full thickness and parallel. So it should be pretty easy to do once you get that kind of idea behind. They always make the incisions in line with the bones, how they sit. So we're not going to make straight incisions, then straighten the bones underneath. You're going to make incisions that are going in adduction, and then the whole foot will correct with the incisions. So this is how I make my incisions. We're going to basically find the confluence between the 4 corners there, between the second and the third TMT joints. We'll put a pin there. We'll put a line across the TMT joints and scribe that out. We also will find all of our other landmarks that we're going to be looking for, which are not typically too many more. Then we'll get under X-ray and we're going to find that the axis of that third metatarsal, make a line there. And that third metatarsal really is the center point. If you're on the medial side, lateral side of the third metatarsal, it really doesn't matter a whole bunch, just matters how long you have to make your incision. I find that if I'm on dead center or slightly lateral, I like that the most. If I'm a little bit medial, you struggle to get over to the far side of the third. So for me, I like to do that. The dissection in between is full thickness. You're gonna open up the sheaths between the long tendons, which is real easy to do. I usually for me, my cases, the long tendon to 2 goes medial, long tendon to 3 goes lateral, but they can go any direction. Right underneath that, you're going to have the EDB and HB muscle bellies. Usually you can tell a difference between them, and usually just find a cleft between them. And then I usually pass something like the speed release between them to just gently pull them apart. One of the biggest things that people complain about is that these are a lot bigger surgeries and they have a lot more swelling. I don't find that with my cases. They are another incision, but I treat those muscles like they're radioactive. I don't want to touch the muscles. The muscles are going to swell and bleed, and I try not to touch them as much as possible. So that's a big tip. On the cadaver, you're not going to be able to see the difference between the EDB and EHB, but in a real live person, you're going to be able to see it. Just find the cleft between them, split them. It doesn't make a perfect in line with the incision you make. It's a little oblique on it, but it opens up real nice and gentle. So it's really quite easy to do. Once you're down to that, you're down on capsules and there's nothing left between you and the bone. Once you get to this point, the joints have to be exposed. You can flex the joint, dorsiflexion just slightly, which will show a little pucker, and you can just open the joint up. What you're going to notice is that it's a zigzag, or what we call a Charlie Brown sweater sign. So it looks like Charlie Brown's sweater, and it has that zigzag across it. And that zigzag is going to have to be straightened out in a moment. But these joints don't have to be released plantarly, but they have to be released laterally. So we have to get on the far side of 3, and we have to release it from 4. The 3-4 interval has to be released. And this is what the tritone was developed for. This is going to allow us to pass that over there, and it's going to allow us to get that ability to close down the wedge that we're creating over there. But once we have the ligaments open and the lateral part of the joint released, now we're ready to plane the joint, make that zigzag into a straight line. So here's the Charlie Brown sign. You can see it there, zigzag on across the sweater. Anybody know Charlie Brown? Now look at the fellows there. They probably don't even know who that is. Do you know? Okay. So we're going to make that line straight. So that's the planer. The planer will go into that zigzag, and that planer will just take that line from a zigzag to a straight line. It's relatively simple. And now we have our ability to put a cut guide in. So cut guide selection, not usually much of a discussion here. Most all of the metatarsus adductus you're going to deal with is going to be corrected somewhere between 6 and 9 degrees of cut. 6 to 9 degrees of cut doesn't equal 6 to 9 degrees of correction. It's an algorithm we're figuring out, but it's a ratio that's somewhere about 1.8 or more per degree of correction on degree of per degree of cut that you make. So we recommend usually putting the 6 on there and looking and seeing if that's going to be correct, 6-degree cut guide. And if it is not enough, we recommend that you close the gap back down and recut on the distal side, get you 3 more degrees, and then that'll end up with a 9. And I would say 99% of cases are going to fall into this that you do normally. Where you have the extremes or you have other deformities that are there, this is where PSI will come in. And we'll talk about that too. So once we make the cuts, we're going to remove the bone slices and keep proceeding forward. So we do have a 9-degree cut guide. When you get an extreme situation like this, where you have probably greater than 35 degrees of metatarsus adductus angle as measured by Scarlatto's angle, you probably are going to pre-predict that you might need to get a 9-degree out and go right from the beginning. How do I know that without measuring Scarlatto's angle, which is a pain? Plumb line. If the plumb line is touching the 3rd metatarsal, I usually will go straight to the 9-degree cut guide. You have to be careful if you have an extremely small female. Extremely small female foot, the cuneiforms are really short, and you don't want to take too much off the cuneiform side. So just be aware that you're also looking at the cuneiform cuts. If they're going to be too big in a 9-degree scenario, you might have to do the 6 plus 3. So this is where we do the double cut. 6 has been done. Oops, excuse me. Apologize, I need to go back a slide. So 6th degree was cut. You don't have to use the compressor, but we recommend those that are new to this, put the compressor on, reclose it back down, put the 6th-degree cut guide back in, and then cut on the metatarsal side again. And once that's done, you'll have an equivalent to a 9-degree cut, and you're not shortening your cuneiforms anymore. Again, I would say the most experienced surgeons aren't putting the compressor back on at this stage, but it's a nice, safe way to learn how to do it and see if you can have that nice reduction and how much cut you can. It also gives you a chance to look at the amount of cut you're going to get under the x-ray. It seems like it's really complex, but it's actually very fluid and easy to do. This is more artistic than it is extremely precise, although you have precision instruments to help you do that artistic correction. So once you get to that point, now you're going to correct, you see how well your correction is done, how mobile it is. We're going to mobilize that and see that it closes all the way down. And then we will put a compressor on there to hold it all as your third hand. Once it's fully compressed, now you can go to your fixation stage. So once the compressor is in place and the provisional fixation is placed in the second. Now, the way I place my compressor is parallel to the bottom of the foot as possible. I'm able to get that everything closed 2 and 3 together, but I still need something in number 2 because I'm going to use the second metatarsal to correct my first metatarsal, and I don't want to excessively pull on the fixation. So we're going to put that in that second pane there. You see, we're going to put an olive wire across that as well. Then you pick your fixation. And this picture is depicting the plates and screws, but today, for me, in most part, I use speed plates on this as much as possible. I'll leave that olive wire in until I'm done with the Lapiplasty portion. So a lot of people ask, do you need to move 4 and 5? As you can see in this video, they generally move without it. And we all know that the 4th and 5th metatarsal articulations proximally are really a different joint. multiplanar, intended to help us with uneven ground. So when you have 4 and 5 adducted, I've never seen a case where I've had to actually do anything except for in a synostosis. Then you might have to break up the synostosis. But I have corrected these in the early days, and it was worthless. I didn't need to do it. And you can't really fuse that joint because you need it to be able to go through the accommodation of uneven ground. Now, a lot of people ask, well, this is a much bigger surgery than a Lapiplasty. Is this the appropriate for you to do this and still weight bear them the same? Yes. You have the same fixation protocol, so you have the same post-op protocol. For us, this is a cam boot for 6 weeks. They start walking the day after surgery. Walking is an important part of this for me because it pushes the blood out of the bottom of the foot. It helps the muscles stay toned. I'm not have as much risk for blood clots. They're not walking far. When I tell my patients you can walk the day after surgery, the answer is you can, but for 2 weeks, I want you to completely concentrate on icing and elevating. So your walking is bedroom to bathroom, couch to kitchen, and curb to door. If you're doing more than that, you're doing too much in the first 2 weeks. But that's for all of my cases. That's Lapiplasty included, and my triple arthrodesis is included. So they're all allowed to weight bear. They're just allowed to weight bear very limited in the boot. After 2 weeks, their swelling is controlled. They've been compliant. They're allowed to walk as much as they want in the boot. I let them do elliptical trainer and bicycle. And when their stitches are ready, they're allowed to do swimming. I don't let them do running and jumping until they get to 4 months. We've published on this quite a bit. Our studies are showing favorable results. We've had, we're now at 24 months showing a very, very low amount of recurrence, and maintenance of correction has been excellent. This is what you should expect. You take a metaductus case there on the left, correct it, this case with speed plates, and you can see a nice, good result. The foot width reduction is pretty tremendous. In this case was 2 centimeters. That's outrageous. That takes somebody from a wide-based shoe to a regular-based shoe or a narrow shoe even. And people love that. And this is the thing about adductus is that it's a case where, yes, they have a bunion, but if you actually look at their foot, it's very, very wide and it doesn't fit in any kind of constructed shoe. So these people usually cry when I take their bandages off the day after surgery because they're so excited with the fact that they can fit into a shoe. And immediately they're there. So what can I answer for you about adductus? I know I kind of went through that really fast. Any questions? Metatarsus adductus is about 35% of the patients who present with hallux valgus. Multiple studies have shown that.
You got like what's your cutoff in that plumb line? Is it the second metatarsal goes past the plumb line at all, or what's your general cutoff?
That's a great question. So I would say in general, that's my rule, but it's not what I stick to. And every bit of surgery is art too, right? So there are cases where I have a really flexible foot and I have the plumb line positive, but it's barely touching the second. And my IM angle started really wide. So if my IM angle is greater than 15 and I have barely touching the plumb line and it's a relatively flexible foot, I may not do the metaductus portion of that surgery. What I'll do is I will try to create a little bit of a negative IM angle. So not really trying to get parallel with my Lapiplasty, I'm trying to get slightly negative. And I also might ensure with things like an Aiken and a what I call a dovetail screw. Because if you have a wide IM angle to start with, that's good for a Lapiplasty or a TMT surgery. You can bring it over, you have plenty of room to work with. 15 is what I've found has been kind of my minimum, 15 IM angle. I don't measure them, but I can eyeball a 15 IM angle. If I have enough, I usually have enough to work with. However, if my metatarsus adductus angle is severe and I have 15 degrees, it just denotes that I have a combined problem. So if I have just barely to that plumb line, I might not do the adductoplasty.
It's almost like you want to measure like your IM angle is measured against your plumb line.
Yeah, true IM.
The IM angle is intermetatarsal. So if you've got adductors, you could have an IM angle of 7
yeah.
and have a severe bunion.
Yeah, very much true.
So it's really from your plumb line.
Yeah, what we call the true IM. Yes. Yeah. Yeah, and then that's a relatively easy thing to do on the fly. You can eyeball them after just a while. What I do quite simply in the office is I keep an architectural ruler, which is one of them triangle rulers, so I have something to hold on to, and I just hold it up to the packs and say, oh, I show the patient, you can see your second metatarsal's in the way, Now, if I'm barely touching it, then I'm looking at the flexibility and stuff. But I will tell you, in my hands, hundreds and hundreds of cases now. My hardest bunion to treat is the very slight metatarsus adductus that I don't treat. So if you told me do it every time I see it, I will tell you it's going to be easier than doing all the tricks to make a slight metaductus not corrected with adductoplasty. That's just in my hands. I will tell you that's the hardest one. So I usually have to pull out a bigger fulcrum, push that base out further, get the IM a little bit negative. I have to do an Aiken almost certainly to get that to EHL and FHL to pull perfectly underneath the metatarsal where you lay it. So it's easier with adductus, and I will tell you I don't always do it. I'm going to do a case tomorrow, and the lady has very slight metaductus, and I'm not going to do the adductus. I'm going to just do the Lapiplasty, but I'm going to pull out the larger fulcrum. I'm going to do an Aiken, and that's what I did the last time for her. And I also put that M1 to C2 screw in, and I'll do it the same on her other side tomorrow. It's a great question. Abshek.
Yep.
Yeah. So you saw the picture there of the speed plate, which has become our go-to hardware. I think last year when I was here, we were just launching speed plate, and I had the privilege of doing the very first case with our second generation speed plate. Speed plate has now taken over the vast majority of our fixation options. Sean, do you have a number of roughly percentage wise?
That's about 2/3 of our now.
And speed plate, kind of a cool name in the sense that it makes you think it's faster. It is, no doubt about faster. In my mind, it's also faster to healing. I saw a patient, and I wish I had my computer up. I saw a patient yesterday, or not yesterday. Yesterday was Sunday, but Friday, and she was 12 weeks out from a triple that I did with these speed plates, triple arthrodesis, and it is, she looks and acts healed. So I mean, I'm cutting her loose. I mean, I'm gonna see her back. I see all my patients back for a year, but it's fantastic. You can actually see rapid healing. And that's my experience. So what is a speed plate? And the reason why we call it speed plate, not a staple, is that it is built off the plates that we had. Okay. So the plates that we had, 100,000 cases. Okay. So we have a lot of experience with the plates that we built, the amount of flexibility in them that promotes that secondary bone healing, allowing a little bit of flexibility into the construct, but good stability because we have them 90 degrees to one another. We took that technology and just built the screws into the plate so that it's a monolithic structure. So you remove some fail points, although they were small, we removed those fail points, but it also allowed us mostly to enhance the action of these plates. With a slight curvature, we can now dynamize this. And we found this, and this kind of evolved from changing our screws from standard pitch screws to fast pitch screws, which hyper compress the plate as it bit into the bone. And we found that by improving that action, we were able to then get the rebound of the titanium and the far side compressed more. So we built it. I say I shouldn't take credit for this, but I mean, I was there testing it after it was built by our engineers. And essentially we'd be able to take these things, dynamize them before we put them in, and then they immediately rebound to the titanium, which is also unique. And it allows this compression on the far side to be much more than available with something like nitinol. So if you think of nitinol as like, we like it, right? Like I love nitinol in a nail. It works beautifully, right? It's just strong enough, compresses down linearly. It's great. But in a staple, I hated it. I had lots of staples break. And I always, and it's maybe because I weight bear really rapidly. Well, nitinol is really flexible. If you ever took a nitinol staple and you just try to bend it, it bends very, very easily. So you can imagine on the far side when loaded, it's just gapping open. And so with the metal we were using, titanium, we found it was much more resilient. And it could be deflected to a certain point. The yield point was not too high, but it also was not overly stiff. So we were able to get it to bounce back. And so once you dynamized and put it in, it pulled the bones back together, especially plantarly, which was really important for us when we want to heal, because that's the tension side of the construct. So it's a really simple thing to use. We have a drill guide that mimics it, and the drill goes in straight. The plate then gets activated to straight and then inserted, and then it will bounce back to its original position. So it's totally new, but using titanium, which I've found to be the sweet spot between stainless steel and nitinol. It's better, in my opinion. And it's versatile. I can use it everywhere. Like I said, I'm doing triples with this, and it's become my go-to fixation for short segment fixation. It's dynamic compression, and it's compatible with smaller incisions because we can get it down to 2 tines instead of 4. And we actually have a hybrid coming in between. We call it the micro quad, which is essentially a 4-tine construct that's going to be into almost the length of a 2-tine construct, which helps with these micro incisions. So comparatively, this is the nitinol comparison here. 1.57 times increase of compression strength, 63x and cycles to failure, and 1.53x increase in ultimate load to failure. When comparing 2 tines to 2 tines. So if you compare the 4-tine, which would mimic a standard Treese plate, it is in comparative to the 2-tine, it's even more significant. You can see 1.7 times compressive force, 88 times cycles to failure, and 1.77 times on the increased ultimate load to failure. So pretty nice increase over nitinol, yet it's not still as stiff as something like stainless steel. So it still allows the bone not to be shielded and work as it should. And you can see we can use this just about anywhere in the foot. The mechanisms for this is really simple. Comes with already preloaded into a kit with all that's needed to insert it. And then you have only a couple of reusable tools that the rep would bring in. And it comes in multiple different sizes, including the large sizes needed to do like the TN and the CC joints now as well. And then very soon we will have the micro quad, which is going to really help that anti-rotation and be able to use through smaller incisions. So I really won't go through this too much. Essentially, you just put a drill guide on after you have your temporary fixation. You then drill your holes, get it prepped. On the back table, the tech will, or you can load it into the inserter. This will load the plate to straight, and you've drilled straight. So you then will just insert it. And it inserts at least 50% with almost no force. And then just the last couple of mallet blows to get it fully seated. The edges of this have been changed from a standard plate to what we call infinity edges, or Sean calls infinity edges, which allows this to just bleed right into the bone once impacted. So it's a lower profile implant, in my opinion, as well. So works really quite nice on that. I think most people are very happy with it when they try it. When we look at it side by side in comparison to a regular plate, if you look at these videos that are going here, you're going to see that it is 465% sped up on the standard plate to keep up with the speed plate when you're looking at them being inserted. So it certainly is a much faster device to deploy. So the picture on the right is going 465 speed compared to the speed plate going standard speed. And so it takes about 45 seconds here, compared to 3 minutes and 15 seconds to put in a standard plate. Now you might say, well, what's the big deal? 2.5 minutes more. Well, it matters, when you're talking about doing maybe a quad where you're putting in, 8 plates. It's a lot. It's a lot of time. So it's a really nice, usually very satisfying. Surgeons put this in their hands. They're very happy. So we use all kinds of different constructs. The one thing I will tell you, as of right now, before we have the anti-rotation micro quads available, when using a 2-tine staple, it's easy to understand that if you have rotational force still available on one side of the construct, you got to be careful. So when you see a 2-tine construct, we are always augmenting a screw to do anti-rotation. So that's the M1 to C2 screw there. So anytime on the first ray we do a 2-tine, whether it's both or one, we're going to use an anti-rotation screw. If you're on the middle rays, 2 and 3, I never use an anti-rotation screw. They seem to be just fine. But I will convert to micro quads when I get them because they're just going to be that much better. So can use them all over the place: transverse fractures, isolated fusions, up to the triples, MTP, that's my favorite thing for MTP, that left-hand picture there. I use that now. I feel like they're lower profile than anything I've used up to now. But if you like that, hold your breath, because you're going to get, Sean brought some gifts for you to look at in the lab, which is our new MTP hybrid plate, which is going to be coming out end of this year, Sean. That essentially is a speed plate hybrid straight dorsal, but it's really super rapid to put in. And we've worked hard on that. We think the MTP is a joint that's going to really benefit from this. The 2 tines are great, but you have to be good at putting 2 plates on. And if you're straight used to that dorsal plate, you're going to love the speed plate option dorsally that's coming. You're going to get to see it today. It's a good privilege for that. Triples, my new go-to for triples. I don't do a lot of isolated TNs. Apparently my podiatry friends do a lot of those. I was kind of taught to never do those, but apparently they work. And they work real well, and you can put multiple in at a joint. The triples when I do these, I actually do a full triple still. I don't do the double or the dipple, but just because I like doing I do a lateral approach, so I'm just right there at the CC anyway. So I still do a triple. And the fractures and Evans, all kinds of things you can do there. So the speed plate's really pretty cool technology. Any questions about where speed plate is? It's about 2/3 of the fixation that people are choosing out there now.
So I have a question partly related to the MTP thing. So we did a study here, actually, a few years back, just looking at like a 2-tine staple orthogonal construct. And the failure rate was high. Most of the studies looking at staples in core bone, show that they're less likely to be effective as like a lock plate. I know that I saw it briefly, so I know that there's a lock mechanism for that, the new MTP plate. But when you're indicating a patient for the speed plate versus a lock plate, do you assess bone quality? Do you think about it? Do you change what you do if there's it's osteopenia or fibrosis?
It's a great evolving question. I do not know if osteopenia, osteoporosis is a contraindication. My gut, I do convert to plates and screws when I'm suspicious of osteopenia and osteoporosis. I had a case just last week, MTP, doing standard plates and screws, and I still struggled getting fixation at the head, and I was using biplanar plating. And I actually hit my pin, bone was soft enough, my traversing pin, and I hit my pin and my whole plate kicked. So all 4 holes, that was the 4th screw, and all 4 holes failed, and I had to move the plate. Fortunately, I had another plate. So biplanar plating is one thing I think is great in osteopenia because it does give you options. But I will tell you, I'm not certain that it is foolproof with this. Now, the one thing that is a safeguard here is that it doesn't keep compressing like nitinol, right? Nitinol has to have a lot of travel to get the compressive force you need. So it's got to over compress beyond neutral. And so it will cut through osteopenic bone. This will only go back to the curvature that we preset. And so it's not far enough for you to actually be worried about it cutting through the bone as much as a nitinol. But time will tell. We don't have a protocol that suggests that we can't use it in osteopenic bone, but you certainly hear the experts and those of us most experienced being cautious. And we just don't know yet. Sean, do you have anything more to add to that since you've seen more cases than I have?
Yeah, I mean, like you said, it's the precedent plates get stability from compression itself. So it's kind of,
Yeah. So I definitely am watching that, but I don't think it's something that's got me overly concerned with this as I did with the nitinol, because it has to go less travel the whole way.
So this is not, the speed plates are just
Titanium. Same metal we use in the regular plates. So the next evolution of things that I'm very excited about is the PSI bunion. Something we've been talking about for years, and it's here, and we've been very excited with this. It's just now starting. How many cases have we done, Abhishek?
We've done about 20 cases.
Including here in Denver, we had one.
In Denver, we've done 2 cases.
2 cases. So it's really exciting. And you might say, well, this is overkill. Well, I don't know about that. I mean, you all have done bunions, and you can tell it's a hard surgery. I still think that bunions is one of the harder surgeries. It's like when I was in residency, and I can remember everybody telling me that distal radius fractures was the hardest thing that we let the most inexperienced person take care of, right? You know, the intern is in the ER, and you all didn't do this anymore. You all take everything to the OR now. But we used to, you know, set the fractures and put them in casts, right? Remember, Ken? We used to do that. And we used to take care of all these things. It's very, very, very difficult to hold in the right anatomic position. Well, bunions are very difficult too. And I think that there's a lot of work, and where we're going in the future can't stop. It's got to continue adding intelligence to what we're doing. And Treese is becoming part of that. And we're very excited for this. I got my first case coming up in a few weeks. And the goal of this is to tackle the full spectrum of bunions, including those extreme cases, revision cases, and even standard cases, which I think is, you know, going to where it's going to end up. And when you look at total ankles and how they evolve, the lack of PSI navigation, you know, kept a governor on how much total ankles were done in the country. Once we got Prophecy as the first one through Wright Medical back in the day that came over from the Inbone, you know, it increased the number of volume of total ankles, you know, logarithmically every year. So it was incredible. Now it's, I don't, you know, they won't divulge these numbers directly, but it's something like 80% of the Inbones are done with Prophecy, or at least intelligent guided. You know, they may not use the Prophecy guides, but they're at least given the guidance on it. And I don't know what the other companies represent, but it totally changed total ankles and how they were done. So you got standard bunions, metatarsus adduction, revision cases, and you know what this does is it's supposed to reduce the intraoperative time, at least by goals, and help take away the unknown things that are going to happen to you during these types of cases. It takes away all those nuances that you're not necessarily familiar with or good at. And so it takes away those things and allows you to get more of this. But for me, the most important part is it really helps you direct what you're going to do before you do it. To me, this is the same principle I have with Lapiplasty, which is correcting everything before I commit to cutting anything. This is the same thing. I'm doing the surgery virtually. So here's a case where we have first metatarsal is deviated 9.4 degrees. You know, you might say, well, that's fairly normal. Dorsiflexion 4.4 degrees, pronated 23 degrees. So it's a hugely rotated bunion. And here's the type of customization triplanar correction guide that you could get, where we're going to give you the corrected position. And I say we again, I apologize. I have nothing to do with this other than telling Abhishek he does a good job. But it goes to the engineers. They're going to do this correction. They're going to give you all this and then tell you, then you're going, you know, you don't have to go through all of the steps of Lapiplasty. It's incision, placement of the guide, and the cuts are made, as opposed to correcting the bones and the cuts have to be made under that correction, which is the old way of doing it. So it's increasing your efficiency. You essentially make an incision, you put your cut guide in place, you confirm it's there, you pin it in place, and then you make your cuts. So the cuts are calculated for you. All the rotation, all the angular transverse plane, and all the sagittal plane maintenance is all calculated for you. And you can overcompensate, undercompensate, correct whatever you want, however you like it. So and shortening the same. You can actually take the shortening in or out of it, however you want. So how does it work? You get a CT scan. Preferably the CT scan is some sort of weight bearing simulated. And that's our preference for how it gets to us. Again, I apologize. I'm using pronouns that I shouldn't. Not us, Abhishek. Okay. But you get the CT to us. If it's non-weight bearing CT, we ask it to be positioned at least somewhat in the weight bearing position. We're still working that out. Which scan is actually the best? Fully weight bearing, simulated weight bearing, positioned weight bearing? We don't know yet. We're working through it, but all of them are acceptable at this moment. Along with regular x-rays and weight bearing if you do not have the foot and weight bearing on the CT. A virtual correct, it will be segmented, meaning all the bones will be separated apart and brought down all the way to the periosteum. So we can see the exact detail of what we need, and then it's going to be corrected. Once it's corrected, and it's corrected and confirmed in all three planes to be the desired correction. So for us, we correct things to a 0 degree IM angle, 0 degree rotation, and a maintenance of the normal inclination that was there pre-op. So that's what the goal is. If you have other goals, they can be built into your surgeon preference. The cut guide is then calculated and preset to that anatomy, unique to that position. And it becomes a single cut guide typically that will then be able to be used to do that cut. Built-in triplanar correction, so it's apply and cut, and quick registration, so it should fit as soon as it put it onto the bone. It's easy to place and pin. The pin's then also used in part for the rotation and such. And you get the pre-op plan just like you would a total ankle. And here's a representative case as it goes through. And you have pictures in the guide, in the plan you get to match up to your fluoro images to confirm. So you cut, you compress, and you fixate, and your fixation choice is up to you. And that's how we're going to do PSI, and it's being done. And if you have cases to do, I'm doing a case that's a relatively straightforward 2-screw, poorly done Lapidus. And that's my first case I'm doing. So we're building it around, I have to make a native cut somewhere because it's long out fused. So I got 2 screws in. We're going to build the guide so it doesn't interfere with the screw. I'll remove the screws. My cut guide will be fitted where we pre-planned it, and we'll make the cut, correct it at one swoop there. It's not something that has to be a revision as your first one. You can do it with regular Lapiplasty, of which now that it's accessible to me, I'm going to be looking for as many people as I can to do it this way because I think it's faster. I think it's going to be more precise and simpler. And I think it's where the future is going. Any questions on this?
Hey, Bob, can you hear me online? This is Jay Kleeman.
What are the costs of the case for?
It doesn't cost me anything. No, it's so there's a cost associated with it, just like in total ankles, there's a cost associated with it. First off, first question is, does the CT scan get covered? In my opinion, it always has. CT scan is for foot deformity. That's what I put it in for. I don't think you put it in for hallux valgus. You put it in for foot deformity, which is what you're correcting is midfoot deformity and surgical planning. And I haven't had one turned down yet. So it's always been clinically appropriate and then fiscally appropriate for the insurance to cover it. Cost of the implants. I don't have an answer for you. I don't know if Abhishek and Sean want to address it, but I will say there's cost. I cannot do it at my surgery center yet because I'm at an independent surgery center. It would exceed the cost that I would get covered there. So I'm doing mine at the hospital right now who don't seem to have a problem with it. So there are increasing reimbursements for Lapidus surgeries coming this year. So that's going to be helpful. Sean, Abhishek, you have anything to say?
Just one comment with the time saved with the cut guide, with PSI, that kind of makes it cost neutral for the hospital in terms of the lower costs associated with that's been a factor for some hospitals, but like Dr. Santrock mentioned,
is there really evidence of that? Like, that's pretty theoretical.
correct, and that's what we're hoping to build through the LMR is collect that data.
But so I guess the answer then to the question is that the hospital's paying for it. Correct. Being so when we go for surgeries, it's like all the stuff like the drapes and all that stuff, and then there's the implant. So this is an implant that's billed with surgery.
It's not an implant. It would just be an ancillary, right? It's an important difference because some insurances cover implants that this would not be covered as an implant.
It's just an expense.
Yeah, it's an expense.
But it's on that.
It's like K-wires and stuff like that.
So there's no so I have a case coming up. Got CT, no problem. Like you said, deformity, arthritis, like there's no hesitation to cover it. It'd be hard to cover bunion for
Yes.
CT, but these are deformities.
It's deformity.
Like simple thing. So CT is not an issue, but
Right.
I just want to make sure that like they're not saying, all right, hospital, pay for this in advance. It goes like you come in, you bring the device in, you say, all right, okay, real big,
Yeah.
These are the PSI guides. It's just included.
It's included in the cost of the kit. That kit costs just like drill bits and stuff. Yes.
Even has a question. Dr. Kleeman, can you hear me?
Yes. Oh, I'm sorry. No, I didn't hear. I can hear you now. Can you guys hear me?
Yes.
Hey, Bob, thanks for that. Couple things. When the speed plate first came out, I thought it was too strong. I took out my temporary wires, had put in the 2 speed plates, and I got some loss of reduction in dorsiflexion and adduction. Asked the reps, no, we've never heard anything like that before. Checked the engineers, no, we've never heard. I mean, literally the first 2 or 3 cases, I had to take the staples out, redo it, and a couple I replaced with the older screws. And then they came out with the longer tines in order to, apparently get better compression deeper. And I haven't had the problem since. So I wanted to hear about that. Number 2, I have a revision case that was done poorly. It is fused. There's still a high IM angle. There's still a lot of pronation. I was thinking of revising it with like a Paragon promo to make 1 cut to get, tri-plane correction and rotation. Does your revision implant? I don't want to take out another wedge. Do you have an option for a revision using the CD technology or the CT technology to make 1 cut and do all the correction through that?
Yeah, I think that it would be really easy for you to talk to the engineers and pre-plan however you would like to do this with PSI. If you want minimal, 0, or major wedges, all can be done based on your preference for the surgery. And they can give you not only can you get this built with cut guides, but you can also just get it as an intelligent guide. They call it IntelliGuide, which is just your options. So that's a service that they're working on as well. So it might be something worthwhile talking to your Treece rep and having them go through this with you, because I'd rather you use our system because it sounds like a great case we could learn from as well.
Santrock, something that they're looking at with PSI cut block too is very minimal.
Yeah.
Angle. I mean, you could do straight cuts.
Yep.
And just look at the rotational.
You could do a straight cut,
aspect.
just rotate it. Absolutely. It can be done any way you want it to be done. So this platform is going to allow us to go any way we want in correcting bunions. So if you want to do just purely a osteotomy with rotation, can be done.
You can plan for a wedge too. If you do want to add no graft,
Yeah, you can pre-plan for lengthening with wedges as well. As far as the speed plate goes, I'm uncertain of what happened in your cases, but the longer tines were added to get far side compression. And so in my unengineering mind, I would say that was actually going to make it actually somewhat stronger on compression. These are not really very significant in that they won't go very far, that they will only go to the curvature that was preset before you activated them. So it might be that it was unstable because of the multiplanar. We did worry about that in the beginning, in the sense that if we didn't fixate one side and have it fixated with provisional K-wires in the other direction, that you might struggle with overcorrecting and having it lose the correction that you had tried to get. So I'm not really sure. It seems to be that maybe the technique has refined a bit since that first series went out. And maybe we can go over that with you again in a peer-to-peer. I think it's now worked out. I think it was probably more technique driven than anything else that when we first put them out, rather than implant itself.
Great, thank you.
On your speed plate, so you want to put it on the opposite side. You want to compress it. So how it works? So it compresses at the far end. So think about latitudes. We want to compress on the lateral side and the plantar side. So now we are putting it on dorsal side and medial side. So that means, and I look at your axial tin joint arthrodesis, and you put it on the medial side. And because we always want to
make sure people from home can hear it. So just talking to them.
Oh, sorry.
That's good.
Because for tin joint arthrodesis, we want to compress on the lateral side. So I'm still working on like in my brain how it works out.
Yeah,
so you put it on the opposite side. You want to compress.
Well, we don't purposely put it on the opposite side we want to compress. We put it on the side we can get to. With the dorsal approach and the medial approach is easy to expose. So we wanted to change the implant that it's favorable to compress the opposite side of where we're working. If we could put the plates plantar and lateral, we would be home no problem, right? You could put a straight plate on there and it would work just fine. But the problem is you can't get plantar and lateral. So we needed a plate to happily enhance, and we're trying to triangulate those tines to that plantar lateral side. And that's where that compression comes in, and that's where we're trying to get to.
And I will comment that we're actually working with Treese in the lab on answering that question. Provide optimal mechanics, optimal compression. I will say that I've done maybe 10, but it's the old bastard. I mean, I've been satisfied with the corrections. Pretty easy, it's pretty easy to put in. So I've had a very good experience, with the speed plates. I've done one plastic. I thought it turned out great. Dr. Plastic. That's right. Yeah.
The way that implants works there is a curve. They compress through the bridge of the implant, and like a 9L staple. So it's got a curved bridge. We straighten it out, and then the tines go into the bone, and it's fixed in the bone. It's the whole bone segment compressed together with the bridge of the implant when it gets released.
The challenge is they're different tine lengths. That's my thought, especially in poor bone, is what you're saying makes total sense if we're grabbing that far cortex.
It's all based on the quality of the fixation.
Or the bones.
Right.
The
whole segment moves together.
But if it's real porous, then you just worry. I'm not seeing that. That's I think that's what's
true. Yeah.
Other questions, because I think we gotta wrap. Let's see if you have more. We're at time. So other questions from the in-person team, from the at-home team or in-clinic team? And hearing none, thank you very much. That was really, really good. We appreciate it. So we're now going to transition to the lab. So there are scrubs in the locker rooms here, and we have how many cadavers? What's our setup back there?
Oh, how many?
Yeah.
7. One of them is a